Good morning, ladies and gentlemen. I'm Dr. Phil Schauer here at the Cleveland Clinic in Cleveland, Ohio, and along with my co-host Adrian Park and Steve Wexner, would like to welcome you all to this edition of Innovations in Surgery. We have a truly outstanding presentation this morning by Dr. Chris Ren and Barry Inabnet regarding the role of gastric banding and gastric bypass in today's bariatric surgery. Without further ado, let me introduce our first speaker, Dr. Chris Ren, very well known to this audience. Chris is from NYU, and Chris is going to talk about the role of gastric banding, particularly long-term results, and she's going to defend the gastric band. Good morning, Chris. Welcome.
Good morning, Phil. It's such a pleasure to be here, especially so early in the morning. I'll be talking to you about my side of the story, which is why gastric banding is superior in the long term. So my disclosures are I'm a consultant for Allergan. I also receive research a grant from them, as well as on their speakers board. So the short-term outcomes, we know that the banding is the safest bariatric operation available. It's a quick and easy operation. It's attractive to many patients and to many surgeons, and it's attractive for the ambulatory surgery center. What we're focusing on, though, is the long-term outcomes of the gastric band. And what we've realized and appreciated that it requires a lot of work and maintenance. And we've also seen in many people's experience that there's up to 10 to 50% reoperation, removal, or revision rate that is required for a gastric band in the long term. And this is partly because it's a mechanical device, and it will have mechanical device issues, just like any other device. Another conundrum we've found that occurs in patients is reflux. So let's define what superior in the long term means. Well, number one, is it how much weight they lose and maintain? Is it superior health outcomes? Is it complications, whether they be surgical complications in long term or nutritional complications in the long term? Is it quality of life, or is it follow-up? So we'll be discussing how do we define the superiority of a long-term operation. So this is just a broad graph that shows what happens with weight loss in the short-term and long-term. And we see with the gastric bypass, there's an immediate rapid weight loss in the majority of the patients in the first 2 years, with a 70% excess weight loss or so. The band actually has a much more gradual weight loss, and by 3, 4, 5 years, there's pretty much no significant difference in weight loss outcomes between the bypass and the banding. In fact, Paul O'Brien's data in the Annals of Surgery recently published shows that in over 15 years, in his 3,000 plus band patients, he had a weight loss of about 50% excess weight loss, specifically 47% excess weight loss at 10 years plus in 75% of his cohort that he followed up, specifically 700 people. And even the patients who required a band revision maintained a similar weight out to 15 years. In our own experience at NYU, of a 6-year follow-up of almost 3,000 patients of our own with an average BMI of 45, we presented this data and published it in 2011. And what we found was that it certainly is safe with a less than 1% mortality, a less than 1% morbidity, and our long-term problems were the usual 5% band slippage, 3 to 4% port problems, a less than 1% band erosion rate, and we had our share of reoperations for weight gain. Now, granted, there's always an attrition rate because patients move around, but it still was less than 1%. And our mean excess weight loss at 6 years was 47% excess weight loss, exactly what Paul O'Brien found at 15 years. So this is quite similar. Next slide. We've also found that the band can affect outcomes in diabetes. It may not be as good as gastric bypass, but it sure does improve it. And in our own experience of over 100 patients in 5 years, we found that when you define resolution or remission of diabetes by a hemoglobin A1C of less than 60%, less than 6, and off diabetes medications, we found that 40% were off all medications and 40% were improved. But there's an issue of compliance, and we know that 60 to 80% of patients will have, so 80% of patients will have either improvement or remission of their diabetes 5 years after gastric banding. But there's an issue of compliance, and it can be, the majority of patients are not going to be compliant in the long term. And what do I mean by that? Whether they're not compliant with eating behavior, not compliant with nutritional supplements, or not compliant with supplements because of cost. If you look at the gastric bypass, if they are not compliant, the worst thing you're going to have is nutritional problems, specifically anemia, hypoproteinemia, and things as severe as osteoporosis and neurologic changes. As opposed to the banding, if the patient is not compliant, the worst thing you're going to get is poor weight loss. So therefore, when you look at the worst case scenario of noncompliance, the mantra of do no harm really is very applicable to the gastric banding as opposed to the gastric bypass. So the other conundrum is, what do you do if the patient does not lose enough weight or they regain weight after the operation that they've had for bariatric surgery? Well, if you have a gastric bypass, you can either lengthen the limb, band the pouch, convert to a sleeve or DS. And those are not easy operations, and they do not have easy nutritional consequences. With a band, you take the band out, or you can convert them at the same time or delayed to a gastric bypass, a sleeve, or BPD. There are simply more options available after a band, and is often technically easier and nutritionally safer. So, what happens if you have a failed band? Well, even if you have 10, 20% of patients who have a failed band and you convert them to a different operation, 80 to 90% of those patients have avoided bowel surgery or intestinal surgery or stomach surgery. And we know that with intestinal surgery or stomach surgery, there's a risk of leak. And when a morbidly obese patient has a leak, they often have a very long ICU stay or a hospital stay, or they have a high mortality, which costs money. The long-term outcomes published out there in gastric banding are multiple, and this is just a smattering of several hundred patients in each group of anywhere between 8 and 15 years out after surgery, and we see that there is a variation in anywhere between 33 and 83% excess weight loss at roughly 10 years after surgery after a banding with very good percent follow-up. But there is a reasonably high band revision or band removal rate, anywhere between 8 and 60% of revision or removal of gastric banding, depending on which center you go to. Two of the highlighted papers that many people that are against the band actually like to look at is Himpin's with his 12-year data of 82 patients where he had a 50% band removal. What you need to know is that these 82 is only 50% of follow-up of their original number of patients. But when you look at those who kept their band, they still maintained a 48% excess weight loss, had a 60% satisfaction rate, no nutritional problems. And you can tell that there was something wrong here because they had an almost 30% band erosion rate, which is even higher than what we saw in the FDA trial, which had suboptimal outcomes when you compare them to present-day US results. And Suter, in his 7-year data of 21% band removal, those patients who kept their band, they had a 60% excess weight loss, which is great. They also had an abnormally high band erosion rate of 10%, which leads you to believe that perhaps if you have a band, you shouldn't go to these centers. When we look at devices overall, they all have an intrinsic failure rate. A VP shunt, overall failure rate is 46%. And actually, it's higher in the pediatric population, which has a lot of operations for VP shunts. There's a 78% reoperation rate. But do we stop doing VP shunts on these patients? Absolutely not. We just revise them or replace them. Joint replacement, there is a failure rate of 1% per year for the first 15 years. Do we stop doing joint replacements? No, we just replace them. It is part of the maintenance of the operation. Cardiac pacemakers, there's a revision rate of 0 to 12%. Do we stop doing cardiac pacemakers? No, we just educate the patient that there's going to be a reoperation rate. Breast implants, 48% revision or removal at 15 years. I don't see a lot of women turning down breast implants because of this. So this is just in the same vein of device development and improvement, which I think we need to embrace and understand and try to decrease as we get smarter in our practice. So there's a change in perception. We finally have gotten the AMA to say that obesity is a disease and it causes other diseases. So we know that weight loss cures these diseases, and surgery is the best treatment for to provide weight loss and metabolic change. We need to look at other diseases. There's never one treatment option. And therefore, for obesity, there should not be one treatment option. It is a multifactorial disease that requires multifactorial treatment options and adjunctive therapy. We know that the band actually has an effect on hunger and satiety. And this was published in 2005, that this is not a punishment of an operation. It is a tool to help with appetite suppression. Next slide. And by knowing this, it can then maintain it for long periods of time. The other thing that we know is that it needs to be adjusted correctly, otherwise it does not work. After gastric bypass, I think many of us have realized that patients after 5 years do have a return of hunger, they do have a return of satiety decrease, and therefore weight regain. So how do you define success of a bariatric operation? Is a 35-year-old, 300-pound woman who does not need her CPAP machine, who cuts down on her medication doses, who loses exertional dyspnea, who gets a better job, gets a boyfriend, and loves life, really less successful if she ends up at 185 pounds and not 175 pounds? Well, that's what we're talking about. That's the difference in weight loss that you would get at 15 years from a bypass versus a band. So the big picture is, we're in evolution. The device technology is constantly changing, and we've seen over the past 20 years there's been decreases in device leak and failure because of development in technology and improvement in the band. There's been a change in surgical technique, pars flaccida now, hiatal hernia repairs at the time of surgery to decrease long-term complications. We've also appreciated that we need more follow-up and postoperative management with the band to achieve optimal weight loss. Complications in diagnosis, we've, again, really learned about early diagnosis and conservative management in order to decrease reoperation. So overall, this is an evolution and improvement in the gastric band technology, surgical technique, and postoperative management that we have to keep in mind. So when you look at these long-term outcomes, this is using some of the older technology and the older surgical technique and may not necessarily represent what we see now. But when you drill it down with these greater than 10-year studies, we see with the banding on the top, you're going to get a weight loss of anywhere between 33 and 60% excess weight loss with an 8 to 60% revision rate or reversal rate, as compared to a gastric bypass, where after 10 years, you can get anywhere between 27 to 68% excess weight loss and a variable revision or reversion rate. So there are similarities here. And when you look at probably the best up-to-date gastric bypass paper done laparoscopically of 242 patients by Kelvin Higa, who is an excellent surgeon, he had 7% follow-up at 10 years, but he increased it to 19% with telephone follow-up and got 57% excess weight loss. There was a 33% failure rate to achieve an excess weight loss of greater than 50%, which a lot of people use sometimes in their papers. And 35% of these patients had greater than one complication during follow-up, either an internal hernia, a stenosis, or problems with nutritional testing, which affected 51% of patients. So of these 136 patients that he followed, only 18% remained nutritionally intact, which is a frightening thing. So if this was a band paper, everyone would say we should never do bands, but it's not. It's a bypass paper from a great surgeon with the biggest gastric bypass experience. It's reality. You hardly ever see gastric bypass patients again. Many of them are malnourished, and many of them regain weight. So we see at least one patient a week who's regained all their weight after gastric bypass. So in conclusion, there's one final disclosure. My husband has had a band for now 14 years in January. He's maintained a 95-pound weight loss. That's 81% excess weight loss by the MetLife table. And he's never had a revision or a conversion or a removal of his band. And so therefore, we're going to keep and stay with our band because it is the best option. Thank you very much.
Okay, great job, Chris. Hey, love the photo of you and George. Fabulous.
Thanks.
So let's hear another perspective on this. We'll go just across town in New York to Barry Inabnet. And let's go to Mount Sinai, please. Are you there, Barry? Welcome, Barry. How are you?
Excellent. Good morning, everybody. Thank you so much for the invitation. I'm going to present today another perspective than Dr. Ren. I'd like to congratulate her on her excellent presentation. I have no disclosures today, and I'd like to begin with a few general observations. All procedures have pros and cons. There is no one perfect procedure. I think there's really a paucity of reliable long-term data. Dr. Ren's presentation certainly reinforced that point. And it's important to note that one size does not fit all. I think if you do only bands in every patient, or if you do only bypass in every patient, you're destined to have worse outcomes. And I think a more personalized approach is warranted. Now, regarding debating, it is important to be prepared and to know your opponent. And Dr. Ren certainly has come out as a strong advocate for banding. But if you look at this statement, this paper's conclusion that bypass as a procedure of choice is biased, unsubstantiated, not supported by the current literature, and represents a disservice to the science and healthcare community. These are very, very strong statements, and certainly is quite controversial. Dr. Ren was one of our first fellows here, and we're not quite sure how the detour to the dark side occurred, but nevertheless, she is certainly the world authority with her husband and team at NYU on banding. So today I'm going to talk about a few band long-term results, gastric bypass outcomes, increased safety of gastric bypass, and a few of the current market trends. So I'm going to be very brief. I only have about an 8 to 10 minute presentation. But if you look at the paper that was cited by Dr. O'Brien, a very important study, 3,227 patients. Overall, the band explant rate was 5.6%, and the reoperation rate for proximal enlargement, pouch enlargement, was about 26%. But the title is very misleading, 15-year follow-up. If you look carefully at the fine print, 15-year data was really available only on 54 patients, which is 1.7% of that 3,227 patients. These 54 patients did achieve an excess weight loss of 44%. So Dr. O'Brien and his team concluded that banding from one center demonstrates durable weight loss of 47% at 15 years. I think this conclusion is flawed based on the number of patients that were actually followed out to 15 years. There is another perspective. If you look at this paper recently published in Sword from Finland, looking at a 14-year experience, 60 patients, 100% follow-up at 14 years. Mean excess weight loss was very good, about 50%. 48% of these patients, however, had to have their band removed, and nearly 70% of those 48 had another bariatric procedure. These authors concluded that banding cannot be recommended as a primary bariatric procedure. So it is easy to pull studies from either side of this issue to support your stance, but clearly the verdict has not been completely settled. Now, what about gastric bypass? What are the long-term outcomes of bypass? Well, let's go back to Dr. Pori's landmark paper. This not only really began the whole metabolic initiative and movement, but certainly there was long-term follow-up in this very important paper. 603 patients, 158 of which had 10-year follow-up. Their excess weight loss was 55%. Only 10 patients at 14 years, their excess weight loss was 49%. But there was metabolic resolution of their diabetes in 83% of the diabetic patients out to 7 years. So Dr. Pori's and his team concluded that bypass is now established as a durable weight loss method. No other therapy has produced such durable and complete control of diabetes, and this really predates the band revolution. If you look at our colleagues from Brazil, 10-year follow-up, again, if you pick the papers that you want to present, Dr. Hika's paper that Dr. Ren presented is one side of the story, but here, 55% follow-up at 10 years, excess weight loss was 67%. However, 14% of these patients did fail their bypass. It's not clear what happened to those patients, but they clearly either had weight regain or a suboptimal outcome, again reinforcing the edict that no procedure is perfect. And they concluded that bypass maintains weight loss out to 10 years. Now, no presentation of long-term outcomes can go without presenting the Swedish obesity study. Out to 20 years, if you look procedure for procedure, bypass at every time point is superior to banding in the weight loss. This is published multiple times, but now there's 20-year data, and you can see that the weight loss is superior of bypass compared to banding. Both are better than the control group. And finally, if you look at Dr. Schauer's team and his recently published study that was presented at the American Surgical Association last April, looking at 6-year data, comparing different procedures, weight loss, and diabetes resolution, you can see that banding, as far as weight loss, was inferior to bypass at every time point, as was the reduction in hemoglobin A1C. So at every time point, bypass had superior weight loss and a more profound reduction in some of the metabolic parameters that we use to follow diabetes. Now, what about safety of gastric bypass? Really, there's been a lot of improvement in bariatric surgery. The lab study, we all know about this, of course, a 10-year observational study. Labs 1 was published in the New England Journal of Medicine in 2009, looking at 30-day mortality. And if you look at banding compared to bypass, the banding mortality was 0. The bypass for laparoscopic bypass was 0.2%. And if you look at the composite endpoint, where there's a collection of outcomes, adverse outcomes, banding had a composite score of 1%, and bypass had 4.8%. So here you can see banding did have a slightly better safety profile, but there have been dramatic improvements in bypass safety compared to, say, a decade ago. Now, if you look at Dr. Berkmeyer's team and the Michigan Collaborative, recently published in JAMA 2010, lap banding, the mortality in 5,000 patients was 0.04%, and bypass in 9,000 patients was 0.14%. And fast forward now, looking at mortality in accredited bariatric centers of excellence. Dr. Nguyen and his team published this last year in the Journal of the American College of Surgeons. Banding 0.04% mortality in 7,000 patients, bypass 0.06%. You can see that bypass now has a risk profile that is almost equivalent to that of banding. Now, what about market trends? What's going on in the market force? Well, again, Dr. Nguyen published this study this year in February, looking at the incidence and prevalence of the different bariatric operations in facilities around the country. And you can see that with the introduction of sleeve gastrectomy, which really began to penetrate the market in 2008, there's been a dramatic reduction in laparoscopic gastric banding procedures. So sleeve is increasing, bypass and banding are decreasing. Another way to look at these same data, in 2008, banding was 24% of the market share. In 2012, 4%. Bypass 67%, and in 2012, 56%. And with sleeve, there's no data in 2008 because that's when it's introduced, but now 37%. Very compelling data. If you look at the Mount Sinai program, from our last academic year, 4% banding, 67% sleeve, 22% bypass, and 7% other. And as some of you may know, there's been a recent merger with Continuum. We are now the Mount Sinai Healthcare System, and we're going to be going from a program of about 400 cases to a program of over 1,000 cases as we merge with St. Luke's, something that just happened within the last couple of weeks. And my colleagues are here with us today for this presentation. Their numbers are very similar, 6% 63% for sleeve, and 31% for bypass. What about around the world? What's going on elsewhere outside of the United States? Well, granted, Dr. Cohen is not a fan of the band. This is a quote. Back in early 2000, banding had a share of around 10%. I'm positive to say that today it's close to zero, and 90% of the band patients were revised to another procedure. What about in Belgium? Well, again, a disclosure, Dr. Hippens is not a fan of the band, but these are the official numbers from Belgium. In 2004, 5,500 bands, 3,300 bypass procedures, 600 sleeve procedures. In 2012, 400 bands, 500 bypass, 300 sleeves. You can see that in Europe, the performance of banding is down. And what about in Australia? Good Dr. Dixon, a huge proponent of the band, sent me these data. In 2012, 5,000 bands, 500 sleeves, 400 bypasses. Clearly, banding in the country that was the founding country of banding is seeing a dramatic reduction where it's less than 50% of the cases being performed. And all is not well for Allergan. They're looking to be bought. They are in trouble. They're trying to spin this off, and they've had a dramatic fall in sales from $296 million to less than $160 million over a 3-year period. And I would say the sleeve is probably solely responsible for this. And they've really hit rock bottom. Just this week, one of my colleagues sent me this email, a Groupon discount for virtual gastric band hypnotherapy reduced from $598 to $99. I think we have hit an all-time low with laparoscopic gastric banding. So in conclusion, I would like to say that gastric banding has a fairly high failure rate and requires a high reoperation rate. Gastric bypass, on the other hand, leads to durable weight loss and comorbidity resolution. Gastric bypass safety profile is approaching that of gastric banding, and gastric banding is being replaced by stapling bariatric procedures, and I think will become more of a niche bariatric procedure than a mainstay bariatric procedure in the next 5 to 10 years.
Great. Thanks, Barry. That was excellent. Both you and Chris have really outstanding arguments, and I love the Groupon ad about reduced prices for banding. Great discounts available. Now, we've got a fantastic audience here, really a worldwide audience. So what I'd like to do is go to some of our international colleagues and get their perspective on gastric banding versus gastric bypass in their homeland. And let's go to Europe first, where the ban really started. The ban had almost a 10-year advance in its introduction over in Europe compared to the United States. And let's go to EarCAD if we could. I see my good friend Michelle Weeks. And Michelle, give us your perspective on banding versus bypass in Europe, or particularly in France.
Thank you, Phil. Two amazing presentations, very interesting. Really, in Europe, the band is decreasing because we know that we found that the band results are quite poor after 5 years, and we have a high rate of reoperation, very high rate. Today, I think that the good question is not between band and bypass. It's what will happen with all the sleeves that are done and that are increasing around the world, and we don't know exactly what will be the long-term results and the long-term behavior of the sleeves. But in our unit, we stopped to put some bands 3 years ago because the results are very bad regarding the sleeve and the bypass. And I think that all around Europe, it's exactly the same. Another thing is that it's not only a problem of surgical procedure, it's also to take your patient in a very good behavior psychiatric team, and all the work you are doing before and after the surgery will help to have better results of bariatric surgery, of course.
the band is not doing so well these days. Well, let's go to another site in Europe, our other European site in London, Imperial College of London, and let's get their perspective. Let's see who is present today at Imperial College. Good morning.
Hello. Hi, thank you very much for your fantastic presentations. We're from Imperial College. We are actually a bunch of residences now attending SCIA. But we'd like to just say that banding was very big in the UK to start with, over 10 years ago. I'm sure you all know that Paul Super has one of the biggest experiences in Birmingham with gastric banding. And although this procedure is less favoured to sleeve than bypass, we find that technique and the operation in the right hands does result in good results. So we'll be very interested to know from Chris what technique, particularly with respect to avoidance of slippage, she employs to get good outcomes. The second point is that we feel patient selection is important. So is band indicated in motivated patients who will work with the band, and does it still have a place in the future? So those are the couple of queries we have. But certainly it is, like in France, getting less popularity, but we feel that there is still a place for the band in the future.
So in the UK, would you tell us what % of all bariatric procedures are now gastric banding?
I'd say about 20%, although I haven't seen the latest results.
20%. Okay. Thank you very much for your perspective. We're going to go down to the Mediterranean area in Israel to Sheikh Sher Zedek Medical Center. And please tell us about banding versus bypass in Israel.
Good morning to you.
Good morning.
Can you hear us?
Yes, absolutely.
Okay. We've had experience with banding for about 14 years, and that was probably the major procedure done certainly in the first 10 years. And I think now, from all the Israeli experience, from about 50 or so surgeons, there's only one surgeon, maybe two in the country, who still perform bands. There have been long-term disappointment from banding. We expected them to be very successful. And I think 8 or 9 years ago, we all felt the same way as Christine Ren feels today. But I think the more experience we gained from banding, the more we moved on to other procedures. And the leading procedure now in Israel is the sleeve, followed, I would say, about between 70 and 80%. And after that comes bypass. So I think we've all moved to other procedures, what we would consider metabolic procedures. And only very few cases of banding are still performed.
Okay, very good.
Okay.
So in Israel, at least, looks like band's on its way out, or at least decreasing, sleeves on the rise, and
Yes.
gastric bypass is stable. Okay, thank you for perspective. Let's go to Dalhousie in Nova Scotia. Anybody from Dalhousie? Do we have audio?
I hope so. Can you hear me?
Yes.
All right. Dennis Clausen here, Dalhousie. Sorry for the low turnout today. There's a lot of other conflicting events. So we have never placed an adjustable gastric band here, which I think is a good thing. I think surgical history, this is my opinion, by the way, informs us that placing a permanent prosthetic device at the GE junction is fraught with terrible long-term complications. So we started doing the sleeve in 2007 when Jaap Bonnier used to be our chairman, and that is the operation of choice here. I certainly can't speak for the country, but banding is done in a few private centers. But in academic and other specialized centers, it's basically sleeve gastrectomy or the Roux-en-Y. There's a few centers doing duodenal switch. I believe they're confined to Montreal, which the McGill people could have told you about had they not run away.
Okay. Okay. Well, thank you for that perspective. It sounds like in Canada, banding is decreasing or representing a fairly small percentage of patients. Okay, let's go to the United States, and let's start first with, let's go to Johns Hopkins. Okay, Johns Hopkins, I understand, just signed off. Let's go to Duke University. And let's see what our friends at Duke have to say about banding versus bypass. Are you guys doing any banding at Duke?
At Duke, we are doing banding. However, I think that constitutes less than 5% of the whole procedure. And still at Duke, about 50 to 60% of the procedures are gastric bypass. At this moment, about 30% sleeves, 5% band, and 5% duodenal switch.
Okay. Thank you very much. I want to get as many comments as possible. We're going to go to Virginia Commonwealth in Richmond, Virginia. I understand Virginia Commonwealth, there we go. They were the biggest advocates of gastric banding. They were the first group to really promote banding. Isn't that right, John?
Well, I would say that I recall being vilified when Harvey Sugarman reported our dismal results with the band. We were told that we didn't know how to do the operation, even though that famous surgeon from Belgium participated in our early banding experience. So we feel somewhat justified now in our earlier opinion. We've always been a gastric bypass shop, but we're seeing a steady increase in the number of sleeve gastrectomies done. Our experience is modest, but it's been very good. We've had very few complications with the sleeve and good weight loss results, but we've done less than 50, to be honest.
Okay.
So I would say I would predict that the breakdown is going to be about 70% Roux-en-Y gastric bypass, done laparoscopically, of course, and about 30% laparoscopic sleeve gastrectomy.
Okay, thanks, John. So it looks like at least the majority of sites in Europe and the U.S. so far say that gastric banding is on its way out. Let's get one more perspective. Let's go to Geisinger Clinic in Pennsylvania. Anybody from Geisinger? So, Tony, what's going on with banding in Geisinger?
We're still primarily bypass and sleeve. We're about 20% sleeve, probably 75% bypass. And if someone comes in begging for a band and needs to lose weight and we'll accept nothing else, we'll put a band in them.
Okay, okay. So what's your prediction about banding over the next 5 years, Tony?
You know, Phil, I think it's going to go the way of all devices in the GI tract. They haven't fared well. Going back to the Angel Chick and you know, the band has not fared well in terms of its long-term durability. And you know, we're looking at that the magnetic ring for reflux, and I have a lot of reservations about it because again, foreign bodies in the GI tract just haven't fared well.
Okay, all right, Tony. Thanks for your perspective. Well, let's go back to hear some final comments from Chris Ren and Barry Inabnet. Chris, I've circled the globe here, and let's go back to NYU, please. And there you go. Chris, we circled the globe here, and the reality is the bands are on the way out. Can you respond to that? As if we have a lot of bad surgeons throughout the world, or patients making bad decisions, or so tell us how do we explain this?
I think this is a natural course of any new operation. I don't think, again, that one operation alone is going to be treating all the disease of obesity. So I do agree with patient selection. I do believe in having a combination of different operations to offer for the patient and patient selection. There's no question about that. And I think what we're seeing with the sleeve is what we saw with the band 10 years ago. It is going on a high, it'll peak, and it'll equilibrate down to the mean. So we will have a combination of things. Just because the band certainly does have a lot of high maintenance and a lot of revisions, I don't think it's a reason to throw it out with the bathwater and the baby. It just needs to be utilized in the right hands with the right patients. Thank you.
Great. Now, Chris, in your own practice, has your, in terms of all the bariatric procedures, I imagine 5-10 years ago, you were probably above 90% for banding. Has your band rate been about the same, or has that declined a little bit too?
You know, the band rate has declined and the sleeves have gone up. But what I found is that there are some people who will never, ever have a sleeve or a gastric bypass. And those are the people that I think will have a disservice if everyone stops doing bands, because we know that the total number of bariatric procedures is going down in the United States. And the reason for that is because there are being less bands done. There's really, the bypass has gone down and the sleeve has gone up, but it hasn't overtaken and taken over the decrease in the bands. So there's an overall decrease in bariatric operations. And that's because patients really cannot accept removing a stomach or reconnecting. And it's a problem for access.
Okay, very good point. Barry, you get the final word here.
Good morning. I enjoyed our debate, Chris. Thank you very much. I agree with most of her concluding comments. I think that a personalized approach is warranted when trying to determine the best choice of procedure. But I think we have a lot of room for improvement, and I think the area of genomics and other areas that are intertwined with obesity will perhaps allow us in the future to better stratify which procedure for which patient, because we don't have it right now. There is no one perfect procedure. I think there will be a role for banding, but I think it will be a very, very small minority of the overall patient population. And I think it's an exciting time. I think we have a lot of work to do, and I think that bypass, when compared to band, hands down has overall superior outcomes. But thank you very much for including Mount Sinai. My colleagues and I are grateful for being able to participate this morning.
Great. Well, thank you, Barry. I also want to thank Chris, Ren. Both of you had outstanding presentations, and I think gave us much, current improvement in our understanding of the role of these procedures in bariatric surgery. And one thing we do know that this field continues to evolve, and who knows, the next 5 or 10 years, other procedures may have come on to the foray, which may dominate the field. So thank both of you very much.